Thank you, Ed. And if you need to stand up and do that heel click, don't be afraid to do so. My name is Travis Nichols. I'm the coordinator for the Region 9 Healthcare Coalition. And we have had a lot of change, just like all of you, in the past couple months within our organization. And I wanted to take a few minutes to outline a little bit about what's happening on the back end with the grant that we received to do this work, and how that correlates with some of the work around the Center for Medicaid Medicare Services Emergency Preparedness Rule. And then ultimately kind of answer the question of who are these new people. That's pretty exciting. So I came back from Christmas, or I came back from a trip last year, and like all of you, I got a Christmas present. And one of those Christmas presents was the Center for Medicaid Medicare Services Rule. It was an exciting opportunity for all of us to embark on a new journey of discovery and learning and preparedness. But I also received a change in the expectations that are associated with the grant that the Healthcare Coalition utilizes to do our work. We're 100% funded by a grant called originally called the National Bioterrorism Hospital Preparedness Program, and now called the Healthcare Preparedness and Response Program. This grant is delivered by the Assistant Secretary of Preparedness and Response under Health and Human Services at the federal level to states across the country. And that grant is then distributed out to create coalitions in our instance to coordinate healthcare with emergency management and public health and EMS for coordinated healthcare response during mass disasters. I share this timeline because it is an incomplete timeline. Many of you know this, but our work in our region started far before this timeline in 1985 when Linda Cox and Ben Hayworth started the Hospital Preparedness Committee under Spokane County EMS. We've gone through a lot of iterations and development since then, but the history of our grant work starts here in 2011 when the anthrax attack followed the World Trade Center bombing. Our nation discovered that we were woefully underprepared within our healthcare sector to respond to disasters and emergencies. That we didn't have adequate coordination between public and private entities, and that we fundamentally didn't have the resources needed to deal with these large-scale incidents that were occurring. So this grant was funded, and it was under the correct auspices of starting to focus on bioterrorism, and we bought a lot of equipment. In the early years in this timeline, we're buying trailers and equipment and a lot of work there. Fast forward to Hurricane Katrina, we learned a lot around coordinated responses with organizations outside of healthcare. And the Hospital Preparedness Program was created in 2006, and the idea of healthcare coalitions were codified in 2008, at which time our work at a regional level, coordinating emergency preparedness among healthcare, really became under the coalition moniker and the capabilities that I'll talk about next. We've had a lot of work since then learning around crisis standards of care at a national level, learning from Joplin, Hurricane Sandy, and our program has gone through a lot of different changes and expectations. The grant work that we work under goes through a 5-year cooperative agreement. And our last cooperative agreement came with a certain set of expectations associated with what we call capabilities. They were 2012 to 2016. And we finished those up last year at the same time that the Center for Medicaid Medicare Services announced its emergency preparedness rule. And that was not a coincidence. The rule was a fair amount of finding from Hurricane Katrina and went through several years of review and development at a federal level before being adopted. And the program that we're funded under was the work we were doing was the carrot, right? It was the equipment for the hospital. It was the training for our regions. It was a lot of the coordination work that was out there to help make everyone better prepared. But this CMS rule really, as you know, is the stick. Suddenly the surveyor is there to make sure this work is being done and making sure that the healthcare organizations are starting to adopt this as a cost of doing business. No longer a subsidized scope of work underneath the grant program as it was delivered previously, but now it's an expected part of the operations of every healthcare organization under the rule. The grant program that we're funded under was changed to reflect that shift in expectation. The capabilities that we worked under previously from 2012 to 2016 were focused on aligning public health work, scope of work under the Public Health Emergency Preparedness and Response Program with these capabilities. The new capabilities we work under are very much focused on healthcare's needs and delivery, and making sure that we're focused on supporting the CMS rule and regulation. The initial measures for our work for the past 5 years were not performance metrics we could measure. That has shifted. Now our grant expects us to very much focus on performing in a way that we can demonstrate value and demonstrate improvement throughout our region's capability to respond to disasters and emergencies. Although we were previously very much focused on collaboration and coordination, we have very much tightened the focus on who we need to make sure are core members in our work. We can't do this functionally without hospitals, without all the healthcare disciplines that support hospitals and their suppliers that support them, EMS, public health, emergency management. And we've got to have all those constituents party to the work we're doing. So we've got a really clear outline of who needs to be involved and what are the appropriate steps to get moving forward. So our work has shifted into these new capabilities. We used to have, Nick, how many capabilities were in the previous grant? Yeah, too many. But pretty simply, now our work is focused on 4 areas. First, making sure that we have a healthcare coalition that's functional and operational to serve you. That means making sure we have the right resources available, that we can effectively use the resources we have, and that we are able to address the work through good structural processes. The second capability is focused on making sure we can coordinate a response. And many of you understand the need to have good situational awareness, good information that can inform your decision making within your organization about where you need to spend resources and where there are gaps that you need to work and request for your emergency management organization. The third capability focuses on keeping healthcare organizations in business. How do we make sure that you have good continuity of operations plans, making sure that whether you have MOUs for resources like water or food, et cetera, that that's structurally in place across the region. And then finally, 4, medical surge. How do we deal with a large influx of patients from an evacuation or from a traumatic event? And how do we coordinate patient placement through those instances? The good news is that we've got a lot of work historically that has built up to this that are kind of plans or processes in place that we've been able to accomplish over many years. So our strategic plan in 2014 laid out some really clear guidance for our healthcare coalition to develop and create the organizational processes we need to serve you. And then we've got a moment here I'll talk about the process that we just started around these capabilities. And then under capability 2, we have our situational awareness process. Casey Schooley, who I'll introduce in a minute, will talk about our essential elements information process and how critical it is during a response to have that. How many of you received our influenza report January, February, kind of what was happening in the system? Fantastic. Thank you for participating in that. If you didn't raise your hand, look at those people that did and ask them what the value was or what they thought was important from that process. Essentially what we do is we send out a request for information, we get it back, aggregate it, and give you a full picture of what's happening in the region. But that's an essential part of our response coordination as we start to work with our emergency management partners. We've started focusing for capability 3 on the CMS process, both with individual outreach, been to many of your organization's facilities, and then also the work groups and information sharing we do through these meetings. And we also have a continuity of operations guide focused specifically on making sure there's good policies available to you or best practices on how to build a COOP plan. And then a place where we spent a lot of time and energy focusing, and many people in this room who are involved with the Disaster Medical Coordination Center process, thank you. Our DMCC plan is essential to our ability to handle medical surge incidents. We've created a Cook County Disaster Clinical Advisory Committee to help us guide the clinical decision making behind resource shortages and allocations during a traumatic incident. And then we've got our ESF8 resource manual that can help our public health partners respond appropriately with emergency management coordination during a disaster response. Our public health partners have led an incredible development around the alternate care facility planning work. Thank you, Cindy. Amazing. And then our Medical Reserve Corps, Dave Burns, here in the audience. If you don't know who he is, make sure you do as you leave. Dave is an essential leader in our MRC's effort to have a volunteer pool of medical staffers who can come out and respond to support whatever the need may be in the community as we start to respond to that. So a lot of work's been done in place to respond in advance, but there's still more work to do. So one of the things that coincided with the CMS rule was an evaluation at a state level of are we doing this work the right way? One of the things in the back end of our healthcare coalition is a reality check to make sure that our resources are being spent in the best way possible. So one of the first steps in dealing with this change in our capabilities or grant expectations is making sure that we're serving the right people. So at a state level, we've gone through and started to look at making sure we're serving the right organizations in the right geographic boundaries. Currently, as you know, we serve the 10 counties and 3 tribes of Eastern Washington. And we work with our Idaho partners here. A little bit of coordination with Oregon on a probably annual basis for this northeast corner. There's not a lot of traffic heading from Wallowa County up north. And then obviously Region 7 and Region 8 here to the west. But at a state level, we started to assess. Any questions before I go on? At a state level, we started to assess how we're doing this work, and are we serving the right geographic area? And one of the things that we started to look at was referral patterns within the medical market. I put this up there. This is actually a commuter transit map. This has, but it was a nice correlation, or at least a visual indication of what we were trying to look at, which is where are we sending patients, right? Where are people moving within the state of Washington where they need medical care? And I thought the commuter map was a nice correlation, even though it's not there, but it does show us that Spokane serves as a regional hub, something all of us know, that we bring patients up from throughout Idaho, possibly Region 8 for traumas coming over our way. It's a reality that we have to work beyond political boundaries and beyond geographic boundaries on occasion. So in doing so, the state looked at our traditional service areas for healthcare coalitions in the state of Washington. In this map, there's 8 healthcare coalitions that serve the state. Us here in Region 9. And then 5 and 6 are served historically by the Northwest Healthcare Response Network in King County. And at a state level for the next year, we reevaluated this and observed several things. One, our EMS boundaries, indicated by these black lines, there's some exceptions where our EMS partners are working in a space that might have a more appropriate referral pattern within the medical market. That our public health boundaries that are designed by or outlined by the color may not reflect what we need to be planning around for healthcare. We also look to make sure that areas of the state where they have traditionally worked across state borders, here down to Portland, Oregon, making sure that we're providing the right resources in a way that's efficient for the state healthcare coalition to function properly and deliver services appropriately. So as an outcome from this assessment process, a lot has changed. I'll show you this next map. This is a former draft of this map. It's not the most current version. I apologize for that. But you'll see some significant changes. Kittitas County, formerly associated with Region 7 here, is formerly, yeah, right. I think the new version has them moving down, if I'm not mistaken. Is that right, Tiffany? Yeah. So this is a draft map, but they've moved down here into Region 8. You'll notice that Kitsap County is now part of the Northwest Healthcare Response Network in the Puget Sound area, acknowledging that Bremerton and a lot of the island areas there do send a lot of their patients into the King County area for care. And then here on the peninsula, Clallam and Jefferson County are not served specifically by a coalition. So what does that mean, not being served by a coalition? It means the state's created a whole nother opportunity or coordination. This black line separates the state into east and west, and we've developed multi-regional services with the intent across the state to find opportunities for collaboration and develop consistency where they might not have been before. One of the great things about a healthcare coalition is that ideally we work with you and reflect, providers' needs and values and build the organization and the response plans that reflect that. That also means that in the state level, we had 8 different response plans in some instances that had 8 different reflections of their provider community. And so being able to coordinate that at a state level was really quite difficult. So the concept of multi-regional coordination was developed to be able to create consistency and cohesion at a broader geographic area so we can ultimately roll up some of these responses to a state level. Make sense? Easy? Questions? So this means that some of these parts of the state here in the Southwest, they're not formally part of Washington Healthcare Coalition. The Southwest region now is working with Vancouver. These organizations are served by the multi-regional services of Western Washington. Here in Region 8, 7, 8, and 9, Kittitas County has moved down into Region 8. We've had some discussions with our partners in Columbia County about whether or not they should remain within Region 9. And frankly, public health and emergency management have a preference to continue to remain aligned with Region 9. Our EMS and hospital partners in that area have a preference to align with Region 8. There's still ongoing development and discussion around where that county will best find its role going forward. All that to say that at a state level, we're just trying to make sure we're delivering the best services possible, to make sure we have the right coordination and the right plans in place. So to facilitate all that, we've got some exciting developments as a healthcare coalition. And I've put an organizational chart up there because we have many new names that are joining us. Spokane Regional Health District is our governing or our umbrella organization that serves as our fiduciary agent. Ed Desi's been with us for quite a while, leading those hospital planning groups that I mentioned earlier in our coalition's history. I've been here for a couple of years now, and I'd like to introduce Casey Schooley. Casey will be presenting after me, but Casey, if you want to stand up and give your quick introduction, I've got a mic for you here for a minute. But Casey is our new training and education coordinator for Region 9. So working specifically within Region 9, our 10 counties and 3 tribes area, Casey's responsible for helping coordinate some exercises we'll talk about in a minute. Casey, give us a quick introduction, if you would.
Well, hi everybody. Thanks for having me here. I'm excited to take on this new position. I come from Lewiston, Idaho. I was working at the North Central Health District down there. I was the training and exercise coordinator for the Public Health Preparedness program, so I did a lot of work in the North Central Healthcare Coalition down there, so I'm familiar with working with coalitions. So I'm excited to get to know everybody and all the partners and all the new faces and everything. So yeah, Travis mentioned I'll be talking about an exercise here coming up, so I'll be reaching out to a lot of you in the near future. Just a quick little background about me personally. I've got 2 kids, 2-year-old and a 4-week-old. We just moved up here in the last 2 months, so it's been a busy, hectic schedule for me the last couple months. But I'm happy to be here, so thanks for having me.
So we're really excited to have Casey come on board. As you can imagine, exercise design has been something that our members have been asking for a long, long time, and we're really excited to have him come on board with the expertise he brings to help provide that service to our region. Also at a regional level, we've got Carolyn Cartwright joining us. She's not officially started yet, but she's able to join us for this meeting. And so Carolyn is coming on board to help us with information sharing and management with our partners. So website, these meetings, all of our newsletters, bulletins, our response process through essential elements information. And I'll let Carolyn introduce herself and a little bit about her background.
Thank you. Like Travis said, I'm Carolyn Cartwright. I have been in the Spokane area for the past 4 years. I'm originally from Oregon. I have my background in exercise science and public health, and then got my master's degree while I worked over at Gonzaga University in organizational leadership. So that's what brought me to the Spokane area, and I have family in the area as well. A little bit about me personally, I love to be outside, so although I am very, very excited to join the team next week, when I'm not in the office, you will probably find me outside. And I think that's about it.
Thank you, Carolyn.
Thank you.
And welcome. Really excited to have you here. So we've kind of broken this up. This is the Region 9 Healthcare Coalition staffing structure. And then here in Eastern Washington, we have some new folks coming on board. Maren and Heidi aren't here today, but Heidi will be starting on August 1st, and Maren will be starting on September 1st. And the 2 of them come with some great background that will help us both take the expertise that Casey's bringing to our region and helping share those practices for exercise planning across Eastern Washington. And then make sure that the 7, 8, and 9 are all exercising in a way that tests our capabilities in an appropriate manner and can start to find similarities amongst our planning efforts to find best practices and share resources where appropriate. Similarly, Marin will be documenting that and helping design response plans that can be used within 7, 8, and 9 where appropriate. And we can build out structures that represent what's in place, but also advance that through better coordination. And I'm excited to introduce Hannah. Many of you have worked with Hannah through different backgrounds, but Hannah is joining us with the Healthcare Coalition formally from Spokane Regional Health District. And Hannah will be focused on information management, so specifically use of WATRAC and the essential elements information process, and making sure that regions 7, 8, and 9 have access to those tools where appropriate. But Hannah, if you'd do a quick introduction, I'd appreciate it.
Yeah, I'm very excited to start my new position as the Eastern Washington Information Management Coordinator. Before this position, I was working on the public health emergency preparedness side, where I was working in mass notification as well as situational awareness. And I did have some background with the Region 9 Healthcare Coalition and cross-training on a few different processes, including the essential elements of information tool. So I was a part of that process for influenza, and we activated that tool this year, and some other projects as well. I'm just very excited to go with a new system of WATRAC. Before I was working in Everbridge and other kinds of programs, and so it's something I'm very passionate about. Something interesting about me is I'm a bit of a space nerd, and so the eclipse that Ed mentioned at the beginning of the meeting, I've been waiting for since I was in the 8th grade, and that is a true story. For real, I have. And so I will be down in Oregon, in Madras, in next month, and I'm very excited to, working in emergency preparedness. We learn a lot about planning and being ready and understanding resource concerns and various different logistics. And so I am planning ahead, and I have all the tools available for me to do that. My dad, who's a firefighter, or at least has 25 years of experience as a firefighter, is coming with me. And so we're going to rock Madras, and we're going to be there supporting, and I'm sure I'll have plenty of stories to tell afterwards.
Thank you very much, Hannah. And so any questions about multi-regional services and kind of what our efforts are there? Again, these are meant to complement regions 7, 8, and 9 and build upon what's existing within the coalitions that are already in place. Finally, I didn't ask for permission to do an introduction for this, but to pull all this together, I'm very excited to introduce Mary Beth. You might speak with her on the phone or by email, but Mary Beth is here to make sure these meetings happen, make sure that we get back to people in a timely manner, and pull our teams together on a regular basis. So Mary Beth, if you're willing, or if you don't want to, it's fine, but any kind of introduction you're willing to give would be great.
Yeah, talk about being caught off guard.
Sorry.
My name's Mary Beth Keister. I am brand new to the world of public health and emergency response and planning, so it's kind of a learning curve. However, I'm not new to the world of healthcare. I have a master's in healthcare administration. I came from Gonzaga Private Counseling Department, so I'm really excited about this world I'm in and a great team we have, and so I'll be happy to help coordinate everything for all these great people.
Thank you. So any questions about our staffing model going forward, or kind of where we're at, things are going? A whole bunch of different functions within our healthcare coalition to make sure that we're meeting members' needs where appropriate. The CMS rule that we'll talk about, I'll mention in a minute, part of this, but one document that I did want to kind of transition to, I didn't make a slide for it, but we do have, so an expectation from us is to serve you better, but then an expectation from members is, what does membership mean? And the question has come up a few times for us by phone or by email. And how do you best participate within the Health Coalition? There's a document printed out back there. I'm sorry I don't have a projection of it. It'll be distributed through a bulletin or newsletter in the near future electronically. But it outlines just basically the expectations to participate in work groups or in exercises or in information sharing, whether you're sharing your best practices here at the podium, love to have you up here, or in newsletters or content sharing. So basically making sure that you're engaged at a level that helps provide content back out to other members or help share your plans and where appropriate. So take a look at that document if you have a minute on the back counter. Ed, Tiffany, anybody else in the audience have something to add to what I missed? Dave, Daryl, Ken? Questions about my quick update on where things are going? Where we're at as a state? All right, more to come. September meeting is our annual meeting. We'll have an annual report to share with all of you, and there'll be some other updates from DOH and other partners. But you're welcome to ask some questions after this if there are.
Thanks, Travis.